Hello, students. How you doing? This is Dr. Tony Scuderi, and today what we're going to do is we are going to talk about the 12 steps in treatment for addiction studies. This isn't going to be a PowerPoint presentation. This is going to be more of a lecture for you. And some of the things that we're going to cover today is therapy and group sessions, as well as individual therapy and individual sessions as well. Knowing and understanding the problem, a look at transference and countertransference, short-term goals in the session, not necessarily those that we're talking about in a treatment plan. That's for another course at another time. Rehabs and the use of the 12 steps and how they use it, paired success stories and the importance of it. And that ties into transference and countertransference, because I want you to take a look at the title, peer success stories, right? Not therapist success stories. And the last part is going to be the use of the 12 steps in. Okay. So let's start with individual therapy. Let's start there, even though that's the second. Therapy in general is a very important thing. Therapy is used to help the patients recover, help the patients understand what they can't understand, help the patients take a look at what they cannot look at, which is basically themselves. Okay. There are two ways of doing therapy: individual and group. Now, group therapy is the therapy of choice for most insurance companies. I remember my early years of study, we started out with individual therapy in psychotherapy as a clinical counselor and as a psychologist. And as time went on, this was back in the 70s and 80s. As time went on, group therapy started to become more in vogue. Okay, and studies were done with group therapy, and it was found that with individuals helping one another within a group context, therapy gets done a lot quicker, a lot easier. It's cheaper to pay for the insurance companies, and people can do this on a long-term basis. And the efficacy was very good for it. So that was one issue. Excuse me. That was one issue with the. I have a little somebody here that wants to bother me a little bit. Toby. Toby usually joins me every once in a while, and sorry, folks. Okay, so group therapy turns around and is very good for the therapeutic process and for individuals. Insurance companies love it. Let me talk to you a little bit about group therapy. When I was studying, and still today, this is one of the foremost books on group therapy. If you want to learn how to do group therapy, you need to get this. The Theory and Practice of Group Therapy by Irvin Yalom. It's a nice thick thing, but it goes into a tremendous amount of stuff. How to do group therapy, what to look for with patients, psychopathology, the whole 9 yards of it. This is the fourth edition. Now I've got editions from 1 through 4. I don't know if there's a fifth one. I really haven't had a chance to look online. But if you ever want to do anything within anything, addictions or psychotherapy, for those of you that may want to be social workers, MFTs, or psychologists, this is the book that you want to get. You'll have a whole bunch of others, but it's premier. The only difficulty with this is he's an existentialist, and some of you may not like the existential viewpoint. You'll learn about that when you have theories and practice. But if you overlook the existentialism, this is excellent. This is group therapy, Irvin Yalom. So the idea of group therapy is to get the whole group of people together in that group. Now, groups should be no more than 6 to 10 people max. Medi-Cal regulations basically stipulate that if you have a group of 11 or more, you need a co-therapist. Okay? And I think it's wise because after about 10 people, you have mob therapy, and it's very difficult to control if you're not really skilled in it. 6 people is the ideal group. You want 6 people in it. The regulations for Medi-Cal at this time sit there and say one person makes a group. Why? Because they don't want to pay for individual. So, however your clinics, as you're going to it, want to define group, that's what you do. So what do you do in group? Well, as you're doing group therapy, it's really important to have the other patients in the group identify with one another, join with one another, and be able to interact with one another to solve problems. To join. Joining is extremely important because groups become very cohesive when they join, when they're together. Um, what that has a tendency to do is it has a tendency to turn around and get your people in the group to support one another, to challenge one another, and to really get them to work through and to look at themselves. Now, even though Medi-Cal and some of the other insurance companies will only pay for groups and sit there and say, just put them in group. I gotta warn you, sometimes group doesn't work. It's marvelous. I use it a great deal. It's a wonderful tool, but sometimes it doesn't work. It doesn't work because sometimes people are not ready for group. Does that mean that they'll never be ready for it? No. It just means that they need to be primed for it. And that's your job to teach them how to do group. Okay? So when you do your psychosocial, feel the person out, talk to them, see how they interact with other people. How did they interact with their friends when they were growing up? How did they interact with their brothers and sisters if they had any? What was their relationship like with their parents? Were they shut down? What happens when they're in a crowd? Are they gregarious? Are they outgoing? Or are they wallflowers and like to tend to stay in the background and not be bothered? Observe them very carefully in individual sessions. Are they talkative or are they pretty much silent? You gotta like be a dentist and pull teeth out of their mouth in order for them to interact. All of these things go into identifying somebody that's workable or not workable in a group therapy process. Okay. How amenable is the patient to advice? How amenable is the patient to suggestions? How amenable is the patient to interacting and opening up and sharing what they are? The other thing you need to look at when you're trying to see if somebody is ready for group or not, are they a narcissist? Are they a borderline patient? What is their diagnosis? I'm from the school that says every addict is duly diagnosed. Every addict has a co occurring disorder. And as far as I'm concerned, that's true. And I will argue this point till I'm 6 feet under and 2 weeks later. Okay. I've yet to meet an addict that does not have a co occurring disorder. Sorry, folks. Some of you may sit there and say, well, that's not true, Doc. I'm an alcoholic, but I don't have a mental illness. No, well, tell me what got you into the alcoholism. Did you feel depressed? Okay. Let's talk about that. Was it a conflict? Could you not solve problems? What's that about? Let's talk about that. All right. Whatever the case may be. Some people will use the alcohol or the drugs to medicate the co-occurring disorder. If you've got schizophrenia, sometimes schizophrenics will use heroin. In the early years, heroin was used to treat schizophrenia because it tended to quiet the voices down a little bit. But the problem with it is when you stop, it gets the voices and just blows them out of proportion and makes it even worse, as it does with depression and everything else. Okay. Alcohol is used for some personality disorders that people will use. You'll see a lot of amphetamines used for people. I mean, all these different things. Once you get into the drugs that they're using, group process can pull out the reasons why they're using the substances. And then from there you can derive and you can start thinking about, wait, maybe I'm also looking at a co-occurring disorder, but I'm not sure what disorder that is. You'll find that out in the group. Now, if that happens, and hopefully it will happen, where you're doing a group and things come out and you're starting to pick up, there's something a little bit more here than just the person shooting up or smoking or drinking or whatever the case may be. Learn your diagnostic and statistical manual of mental disorders for DSM-5. Okay? Learn it. Unfortunately, we don't teach that here. We don't have a class in psychopathology. It's beyond the scope of the certificate program. But trust me, it should be part of it because you're going to need to know it. Not that you're going to diagnose, but that you're going to know what the diagnoses are so that when you see the signs and symptoms being brought out in a group process, you know what you're looking at. So once you know what you're looking at, now you can take that patient and you can refer them to psychiatry or psychology, right? And your notes of that will be very pure and very secure. This is what I'm looking at, and you do your note. And that note goes with the patient to the doctor who reviews it, takes a look at it, and says, okay, let me take a look at this and see if this is what I'm looking at. And the doc will review it based on your notes and sit there and say, okay, this is what I'm looking at, or this guy's totally off. Let me see what I'm dealing with. At which point the diagnosis changes. That goes into a note from the doctor, and you should get that note back to read it so that you know what you're saying. So what do you need? You need a release of information. So if you make a referral to the patient, HIPAA compliant, and to be 42 CFR Part 2, Part 8, Part 4 compliant, you need a release of information to be sent to the psychiatrist or to the psychologist or whoever the patient is dealing with in concert with you so that you two can exchange notes and you two can talk to each other. Very, very important. Not that you're going to reveal any of that stuff in group. You're not allowed to do that. That's confidentiality. But at least you have an idea of what you're looking at. If something happens in group, you'll be more equipped to deal with it. Okay? And you should be able to do that with all of your patients in group. So the ideal group is 6 to 8 people, 10 people max. Medi-Cal says that if you have 11 or more, you get a second therapist in there at your level. As if you're just starting this program out, you're going for a first certificate, and it's going to be a registered alcohol and drug trainee or technician or whatever they call it this week. You should not be in there alone. You should always have a trained uh, counselor in there with you. We call them a KDAC 1, Certified Addictions Counselor Level 1, Level 2, Level 3, or a licensed person in there to sit with you. You can run the group, which is fine, but they should be in there just in case you get a little bit stuck in trouble. The anxieties in the beginning of group process and all that, which is normal and great, but you should never be alone. Unfortunately, clinics sit there and think that once you've got your certificate and your credential, you know everything. So some of them will sit there and watch you for a week and then throw you into group, and you panic, and patients don't get better. That's for another class. That's for an ethics class. But for group therapy, it's very important for you to understand that. Okay. So let's talk a little bit about group therapy and what you're going to see in group therapy. You're going to see a lot of different patients. You're going to be seeing all ethnicities, all races, creeds, nationalities, colors, sexual preferences. Um, Everything is going to be thrown in there. Every patient is unique, and this is something that you need to understand. You cannot treat every patient with a template. It's not going to work. Every patient is different. Every patient needs an individualized treatment plan, and you can't copy and paste, because one treatment plan does not really work well for another. So some of these things may, but most of them aren't. So you've got to tailor the treatment plan to the patient's needs. When you tailor a treatment plan to patient's needs, the main area that you're going to get that information from is number one through your interview and number two through your psychosocial. Okay. The interview of the patient in the beginning is extremely important. You need to understand and you need to learn interviewing skills. So go to a workshop, get some training, read, ask me, drop me some lines, and I will give you some stuff. I will cover that when I talk about theories and practice and the practice part of it. But your interviewing skills are extremely important because that's going to draw from the patient the problems and the issues, both overtly the ones that they tell you on the outside, and hopefully covertly those things that are on the inside that are very painful and repressed and suppressed and very, very deeply buried. So your interview is going to be very important. Second thing is your biopsychosocial. Biopsychosocial is a very lengthy document. It's basically the story of the patient from start to finish. Regulations of Medi-Cal You usually sit there and give you, and some of the insurance companies usually give you 3 days in the clinic to do a biopsychosocial. You have 3 days to complete it. Okay. I do not like to do biopsychosocials in 3 days. I like to do them in one day. That's just me, and I've been doing this forever. But there's a reason for that. Over the course of 3 days, the patient can, forget things, or you can forget things, and somehow the tension within that just isn't the same. So you really can't take a look at the patient visually over the course of 3 days as you would on the first day, and start to notice the nonverbals. But sometimes, if it's a new patient that's in therapy for the first time and you're doing a psychosocial, the nonverbals are extremely important as well as the verbals. You what the patient doesn't say can write a book, but you got to know how to read the nonverbals as well. And that can be done, either face to face. It can also be done, through something like Zoom or whatever the case may be, especially in this modern day and age. There's nothing like face to face. Okay, so your intake is going to be very, very important. And from there, from the information in the psychosocial, you derive your treatment plan. Right? You take the stuff from the biopsychosocial, you discuss it with your patient, and when you formulate a treatment plan, I'm of the school of you do a treatment plan with the patient in the room with you. Do not do a blind treatment plan. What I mean by that is don't just read a psychosocial, put something down in the treatment plan, stick it in front of the patient and say, here's your treatment plan, sign it, and have the patient sign it and then go willy-nilly in whatever you want to do with therapy. Don't do that. A patient has to be part of the treatment planning process. The patient needs to buy into the treatment planning process, and the patient needs to sit there and say, "I want to complete these goals in a treatment planning process." I will teach you treatment planning again in another course in planning. Okay, but just let it be sufficient right now to say, don't do it in isolation. Do it with the patient in there, and draw it from the psychosocial. All right, from the initial interview and from the psychosocial. And once you've got all of this information, right, and you understand diagnostics a little bit, so that when you look at the patient, you know what you're looking at. And again, let me reiterate this: you are not there to diagnose. You're there to understand what you're looking at, take very clear notes, and refer that patient to psychiatry or psychology. Do not try to sit there and psychoanalyze a patient and diagnose a patient. That is totally wrong. That is unethical. And if you were in my clinic, I would fire you on the spot. You don't do that. Okay. But what I would expect you to do, I would expect you to know what you're looking at. If a patient comes to you and tells you that they're hearing voices, you should know some questions on what to ask, document the stuff, keep the patient calm, go to your supervisor and sit there and say, "This is what I got in group. This person needs a referral," and go do the referral. Okay. Now, when you do that referral, understand that one of the things that is going to be very, very important, along with you understanding the referral, is a release of information, so that you can talk to the psychiatrist or the psychologist or whoever you're referring the person to. That's going to be extremely important. Put your ego off to the side. All right. You are not in isolation when you treat a patient. Right? You need to do this in concert with what we call a milieu staff, which is a conglomeration of many disciplines. Psychiatrist is going to be a tool that will be invaluable to you, right? Because if you get a psychiatrist to talk to you while you're doing your group or your individual sessions through your notes or through phone calls, you will learn a lot throughout the years. I have, okay? And I know you will too. But if you think that you know it all and you can handle this and you can do it, you're going to be one of those people that's going to hurt your patient. So please get a release of information, discuss things with the psychiatrist, so that when the psychiatrist treats the patient and passes the patient back to you to do the drug and alcohol treatment, you know what the psychiatrist is working on, so you can watch what's happening and document accordingly. And then when you send that patient back to the psychiatrist for med checks or sessions, whatever it is, the psychiatrist can look at your notes or have a verbal conversation with you, so that the psychiatrist can say, "Oh, so I see that Dr. Tony is working with you on this. Is that what he's doing?" Yeah. So, and then the psychiatrist will do his or her thing. Okay. Um, very, very, very important. You are going to be the one mainly in charge of your patient, because most of the time psychiatrists will only see a patient for maybe a med check. Some really good psychiatrists will see a patient for an hour. I know for one thing, my wife is a psychiatrist, and one of the things I admire the most about her, she's not a traditional psychiatrist. She will sit there with the patients and do psychotherapy, right? As opposed to some of the psychiatrists, they'll sit there and say, "How you feeling today? Your meds working? Okay. Continue taking your Haldol 10 milligrams once a day. All right, see you later. Next, come on in." Very, I don't know what you would call that. Um, but if you get a psychiatrist that works with the patients, you will learn a tremendous amount. Okay. From there, once you are finished your uh, biopsychosocial, your initial interview, your initial treatment plan, and you put the person into treatment, the designated treatment. You have group and you have individual therapy. Most insurance companies want you to do group. Why? Because it's cheaper and it's also efficacious. It does work. Some people, however, you have to understand, are not group ready. They have to be made group ready. And this is a problem because if they're Medi-Cal patients, Medi-Cal just says, no, just put them in group. They'll get used to it. These patients usually leave group, don't finish, shut down, relapse, have problems, are argumentative, and also be verbally abusive, within the group process. Very angry patients, they will shut down, because they're just not ready. It's not that they're bad patients, right? It's not that they're too sick. It's not that, they're not disciplined. They're just not ready, right? There are some patients that you're going to get, that are sitting there saying, "Oh my gosh, I'm sick of being sick. I'm sick and tired of being sick and tired. I'm ready for recovery," and they're not ready for recovery. And they're going to come to you, and they're going to be gung ho, and you're going to think you're doing a great job, which I'm sure you are. And then all of a sudden, you don't see them for a while, and you find out they relapsed. You're going to feel bad, but you shouldn't, but you feel what you feel, and they're going to come back and say, "Oh, I messed up again. I relapsed." They're just not ready. And also, the disease of addiction is really bad. And when you study physiology and pharmacology, you'll find out other reasons why they relapse, other than self-control and the brain disease operates. But all of this stuff is very important as to what's going to happen in a group and how the group is going to work and why the group is going to work that way. And that all depends on you. Okay. So when you're in group, as I said, it should be 6 to 8 people max. Usually 11, you get a co-therapist. And if you're just in the initial fledgling stages, an RADT, registered person, not a counselor yet, somebody should be in there with you. Um, Allow the group to do what's known as a process. As I says, one of the things that will teach you again is this book by Irvin Yalom, The Theory and Practice of Group Therapy. Group psychotherapy. Okay? It's a very good book. Um, and again, I can't say enough. Buy it. This is you're going to be using this throughout your career. I still refer to it, and I've been doing it for over 30 years. But I still refer to the Yalom's work all the time. So start the group off. The people are gathered around you. When you do this, landscape your group in such a way where you are near the door. Keep your chair near the door, and nobody sits in your chair. So your chair should look a little bit different from your patient's chair, right? Because as Yalom would say, you're part of the group. You know, join with the group, but yet you're away from the group because you're the therapist. Don't share your stuff in the group, right? Because you start doing that stuff, then you not only become part of a group, but you also become a patient in the group, and that's not a good idea. Okay. So what you wind up doing at that point is you do your group. So you have your patients around you. You're by the door. Another reason for that is safety. Let's say somebody acts out and gets violent. Get out of the room. If you're sitting distant from a door, you've got to cross the room and go out the door, which basically means that the person is angry and they can attack you. Your job is to be a therapist, not a bouncer. Okay. And I know, you may sit there and say, yes, but, who's going to watch the patients if you got a violent person in there? I'm going to say something that's not going to be very nice. You ready? I don't care. Get out of the room. All right. It's not about the patients at that point. It's about you and your safety. Your safety comes first. Patient safety comes second when something like that happens. You get out of the room, you call somebody, and you tell the patients, get out of the room, clear out of the room. All right. Never, ever, ever touch a patient, especially a violent one or somebody acting out. You touch a patient, that's it. You're done. That could be seen as assault. And if you hit the patient, that's battery. Be careful. Get out of the room and then let everybody else clear out the room and shut the door. Patient's in there that's angry and he's trashing the place, great. Let him trash the place. Get everybody out after you leave and shut the door and call somebody. Call the supervisor, yell, scream, whatever, get somebody else in there. And that's it. Okay. Your job is to treat, not to be a bouncer. If any clinic tells you, no, patients come first, you wait in that room, until the patients are going, and then you leave. Don't go for that clinic, right? Don't leave. Go find another job somewhere because that clinical director doesn't care about you. All that clinical director cares about is, money. All right. If that clinical director was smart and worries about the money, then the clinical director is going to say, you get out of the room first, call somebody, and try to clear out the room the best you can. But if that patient that's crazy comes running out after you, run down the hall and get away from the patient. Right? That's what you want. Enough of the safety stuff. So let's say you have a normal group. So you have the patients in the group and introduce yourself. Hi, thanks for coming here. I'm Dr. Tony Scuderi, and I'm going to be your therapist for our sessions together. And I'd like to get to know each and every one of you. I know sometimes it's uncomfortable, but I'd like to go around and I'd like you to tell me your name and give me a little bit if you want, a little bit about yourself. If you don't want to, that's fine. But why are you here? Okay. Now, before you do that, I do want to tell you something that this is not an Alcoholics Anonymous group. So I'd like you to get out of saying, hi, my name is John. I'm an alcoholic. Okay. Now, let me back off for a moment. Why am I saying that? Because your groups are not AA groups, nor should they be run as AA groups or NA groups. Okay. These are therapy groups. So you want to pull away from the AA bit a little bit. In AA and NA and all of those self-help groups, part of the thing that they do is, hi, my name is John, I'm an addict. And everybody will sit there and say, hi, John. And then John will tell the story. It's called catharsis and unloading. Okay. Old psychotherapy term. So as John catharts and as John tells the story, he tells what he has to do, and he sits down and says what at the end? Thank you for sharing. He sits down, somebody else gets up, tells their story. Thanks for letting me share. Thank you for sharing. And somebody else gets up and the cycle repeats. That's an AA group. What's not happening there? What's not happening there is what your group is to do, and that is process what the patient is saying. Back to the patient. I've never been to an AA group or an NA group or a closed group, at all that sits there and the chairperson or somebody in the group is going to sit there and say, "Oh, hey, I hear you. This is what you're saying, and what I really hear you saying is this, and you need to look at that, or you're in denial here because of no." That doesn't happen. They'll listen, they'll sit down, and they may say, oh, talk to somebody after the group. You it looks like we have somebody here that needs some help after the group. Somebody can talk to them, but they won't do that within the process of the step meeting. That's not your job. Your job is to do counseling. Your job is to do therapy. So what I do, is I'll usually sit there and I'll tell them that, please don't make it like an AA group. Say, hi, my name is John. I'm an alcoholic. Just say, hi, my name is John, and I'm here because I want to deal with my alcohol problem. It's a little bit different than saying, hi, I'm an alcoholic. It's one thing to name and claim your addiction. Okay. It's another thing to turn around and to say, this is who I am, and this is why I'm here. This is the purpose of me being here. Sometimes when people turn around and say, hi, my name is John, I'm an alcoholic, or my name is John, I'm cross addicted, or my name is John, I'm a drug addict, whatever it may be, that makes the patient feel, some of them, at least some that I've had and I've treated, makes them feel self-blaming and shaming, right? And that's not really what we want to do. We don't want to shame the patient or have the patient shame themselves. I mean, my God, they're down and out as it is. They've had a drug addiction or alcoholism for how long? How much damage have they done to people, places, and things, right? Including themselves. They've got enough shame. They've got enough anger. They've got enough fear. They don't need to sit there and say, on top of that, I am an addict. In other words, I am a bad person. Now, I also know and understand, don't get me wrong, that you're that part of the philosophy is you're acknowledging what you are. That's why you go to an AA meeting and say, hi, my name is John, I'm an alcoholic. You're acknowledging it. I'm not denying that at all, right? But what I'm saying is there's a time and a place for it. Yeah, acknowledge in group that you're an addict and an alcoholic, but frame it in such a way where you're not sitting there saying, hi, I am. What, are you proud of being an addict? Proud of being an no, take that out of the context. Not that you're proud to be one in a meeting either. Don't hear me saying that, because I'm not saying that. What I'm saying is, when you're in a meeting, it's fine to sit there and say, hi, my name is John, I'm an addict. The meeting is for. In therapy group, sit there and say, hi, I'm John, I'm an addict. The next follow-up question to that is, why is it important for you, or what makes it important for you to sit there and say you're an addict? That's a great start for a group. Well, if the person sits there and says to you, hi, my name is John, I'm here because for 10 years I've had an alcohol problem and I'm just tired of dealing with it. I want to deal with it here. I don't know how to. Don't say anything in the beginning if you're doing a what do you call that? Introduction of the. Thanks, John. Would you like some time during group to talk about that? They say yes or no. Move on to the next one. Next person. Hi, my name is Sarah. I'm here because, well, I've had some difficulties with substances and I was told that if I don't go to therapy, they're going to take my kids away from me. Okay. Thanks, Sarah. Well, you need time. No, great. Well, I appreciate your honesty. Next one. And you go down to everybody and make sure that everybody says something. At this stage of the game, in the initial part of group, do not turn around and sit there and tell the person you can pass. No, I don't want to hear you can pass. Say something about you. What brings you there? My name is Jack, and I'm here because my PO told me to come here, and I don't want to be here. I think it's a bunch of bullshit. Okay, thanks, Jack. Appreciate you sharing that. You know, as you're sitting there going like, oh boy, in the back of your head, now I got to deal with this. Yeah, you got to deal with that because that's what you're going to get. All right? Once you go around, now it comes to you. This is where it starts getting very tricky. If you're in recovery or if you're not in recovery, all right? A lot of clinics will sit there and say, it's fine for you to sit there and tell the patient you're in recovery. Hi, my name is Fred. and I'm a recovering addict, and I've spent all this time, I got 10 years sober, and I decided to become a therapist, and that's why I'm here. I like helping fellow addicts. Well, that's wonderful for some people, but do they really have to know that you're an addict? Are you there as a therapist because you're an addict, or are you there as a therapist or a counselor, whatever you want to call yourself, to help the patient? Right? My patients don't know if I'm an addict or not. You may not even know if I'm an addict or not. And I'm not going to tell you because it's not that important for me. Now, you may argue that, sit there and say, okay, fine. But here's the problem. What if I'm not an addict? I've been doing this a long time, right? And I'm quite good at it, I think. But what if I'm not an addict? And patients in the group, wise guy, that sits there and says, "Oh, hey, doc, you in recovery?" And I said, "Oh, no, I'm not in recovery." Next response is going to be, "Well, then what are you doing here?" "Well, I'm your clinician." "Yeah, you can't be my clinician because you're not in recovery. I don't believe you can help me." "What makes you think I can't help you?" "Because you don't know how I feel. You can't relate to me." Well, I just shot myself in the foot. I sit there and say, "Hey, doc, are you in recovery?" "Yeah, I'm in recovery. Yeah, I've been in recovery for however many years, 10 years." "Oh, great. Now, what's the next question going to be?" "What are you recovering from, doc?" Flip the session. So it's none of your business. How do you tell a patient it's none of your business? Just know that I'm in recovery. I've seen many counselors sit there and say, "Well, man, I've done cocaine. Boy, I used to love it when I used to do it, but I'm not doing it now." Well, TMI, man, too much information. Not for patients because that validates an addiction as far as I'm concerned. Now I'm going to have counselors that sit there and they're going to argue with me. People that have been there for a while, people that are in recovery or not in recovery, there and say, you can't say that. Well, I've just said it. So what do I tell a patient? What I tell a patient is, well, before I answer that question, what makes it important for you to know if I'm an addict or not? Because, you know, if you're just going around for the introductions and somebody asks you that, don't answer the question. Say, let me come back to that and then do the rest of it. And then go back to that person. What makes that important for you? What is it about me that you want to know? And then listen to what they say. And then to the rest of the group, you say, so he may sit there and say, well, because I want to know if you're in recovery or not, so that you can understand where I'm coming from. Hmm, the group. So how many people here in the group believe that if I'm in recovery, I will understand where you're coming from? Could you raise your hands, please? Okay. Let me ask you another question. If I'm not in recovery, how many of you think I can help you or not? And you could raise your hands on that. Oh, I see not too many people raising your hands. Now you point to somebody. Could you tell me why you don't think that if I'm not in recovery, I won't be able to help you? What's that about? Now you've got a group process going. So the first group is kind of like a feel me out group and feel the group out group, so that you can turn around and understand what's going on, and they can, the patients can take a look at you and see if size you up and all that. Okay, that's very important. So now the group is over. Thank them all for coming. See you next week or tomorrow, whenever the next group is. They come back. You don't have to go around with, check-in again, as you call it. You can if you want, but you don't have to. Sometimes in groups, they have on the wall the 12 steps and also the group rules and regulations. Let them read it, every group, at least you get something started, and then do the group. To start the second group and groups thereafter. I usually like to begin with, thanks for coming. Hope you all did well. I'd like to open the group up to you. It's not a topic oriented group. That's another story. I'd like to open the group up to you right now. Would anybody like to start? Anybody like to say anything? how you're doing, your recovery is going, what kind of issues. Now, sit back and be quiet for about a minute. Don't say a word. Don't. The anxiety is going to build, but don't say a word. Let somebody talk. Look around, scan the room, right? But don't say anything. Nothing is said after about a minute. Sit there like this and go, hmm, you're awful quiet. Somebody tell me what the silence is about. That's a good lead in. And look around. Oh, Chris, I see that you've been awful quiet. What's happening with you? How are you feeling? And if he comes up with the anxiety, oh, I'm okay. Okay, what does that mean? Oh, you're fine. Not sure. What do you mean by fine? What is fine for you? I'm okay. Chris, you said you're okay. You said you're fine, but I don't know what that means for you. Could you tell me a little bit more? What makes you okay? What makes you fine? Probing questions, right? And then once somebody starts to talk in a group, this may happen in the third group or so, and somebody sits there and, you know, folks are here to recover from your addictions. Who'd like to talk about their addiction today? How many people do we have in here that have, had some difficulty? Somebody may answer. Now, at this point is where you got to start thinking. One of the things you may want to do to start a group moving, if it's dead silence, is today I'd like you to talk about how many. Oh, by the way, how many people here have an alcohol problem? Raise your hand, please. How many people have a drug problem? Good, thank you. I'd like to talk a little bit about the addiction problem. What got you started? I'm very curious about that. What got you started? Now, somebody's going to turn around and say, well, this is what happened to me and happened to me and happened to me, right? Start thinking like a clinician. Is the experience of trauma? Is it due to some doctor that gave them pain medications and they got addicted to it? Is it a family systems issue? Is it a psychopathology? Whatever it is, start putting your thinking caps on. And then as the person is talking, you sit there and give your nonverbals. I see. Well, thank you for that. Try to stay away from. Thank you for sharing. Because you do that with everyone. After a while, somebody's going to throw something. Appreciate that. Thank you. Then here's how you start the group. Can anybody relate to what Mark just said when he was talking about, and then you paraphrase what Mark said? Mark had some very interesting things. He talked about this and this and this. Can anybody relate to that? Now they may raise their hand. Yeah, go ahead, John. Go ahead. Mary, what you got? Oh, I saw you, Fred, raise your hand. Also, what's up with that? Get them there, okay? Then after that's done, after you've talked about it, so we all see this as a problem and as a difficulty. Then you go back to the original person. Right? So John, tell me, how did you deal with this other than using drugs? What worked for you? Now we start to go into the recovery process. What kept you sober, John? Let John talk about it. Okay. Anybody else? What kept you sober from this? Can anybody tell me? Then let them talk about it. Now you've got a group going. Couple people start talking, let them talk, and then monitor and look around the group. Watch the group, look at the people, because there's going to be some that are just going to sit there in silence and do absolutely nothing. It's okay for the first group, maybe the second group. Third group, this is where you want to draw them in, right? Because now they're starting to get too comfortable in their own stuff, and that's what gets them in their addiction. So after a couple of people, sure, you sit there and you say, well, Ryan, I noticed over the past couple groups, you're not saying too much. I'm curious, what's going on with you? Oh, nothing, nothing. I like to, I'm the kind of person who likes to sit there and listen, and I'm soaking everything in. Could you tell me some of the stuff that you're soaking in? How to stay sober? Oh, like what? What works for you? Pull them in. Don't let them sit there. Draw him into the group. And then once he starts talking, wow, Brian, that was a great amount of stuff. Can anybody relate to Brian? Does anybody want to give Brian any encouragement? Now you pull the groups in to interact with Brian. So what? Brian feels uncomfortable. He may give you a look or something. Whoop-de-doo. You're not there for a beauty contest or a treat. Okay. So we got group and the dynamic of group and how to do that. Before I close, I want to talk to you a little bit about the three types of groups that Yalom talks about in this wonderful book. Okay, I should say the three processes that occur in groups, not types of groups, but the processes. Three things that happen in group. Part one of the group, after you've gathered the group, we have the group members that talk through the therapist. Stage one is talking through the therapist. What does that mean? If you got 8 people around, and let's say they're kind of getting used to one another, and they want to interact and talk with one another, they're not too sure, especially if it's a new group. If it's a group that's been there for a while, this won't happen because it's already done. New group. So they're going to talk to you. Well, when John was saying that he was using alcohol, I could really relate to that. Stop the person right there because they're talking to you. Sit there and say, well, wait a minute, let me just stop you there. No disrespect. Let me just stop you there for a second. Why don't you talk to John and point to John? Why don't you talk to John? Say, could you say to John, when you were talking about, and then talk to John about it. So let him do that. Pointed him over, and then just sit there and then let him talk to John about it. And then what's going to happen? John may either talk to him directly or talk to you to talk to him. All right. So if John starts to talk to you, just sit there and go. You don't even have to say a word. And if he doesn't get it, then you say a word and say, no, talk to Brian, John. And then after they're done doing their discourse with one another, can anybody relate to what John or Brian are saying here? Well, you can. What are you saying now? Well, I see. Look around. You keep eye contact, but you look around. Can anybody relate to that? And it's going to come back to you. Now all you have to do is just point, say, oh, fine. All right. So stage one. Stage one is talking through the therapist. After a while, and there's no time limit on this, after a while, what winds up happening is, the group starts to feel comfortable. And now they want to jockey for position, your position. They want to be the therapist. And this is great when this happens. If you know what you're doing, this can be a lot of fun. We'll have some people in the group that are old timers that have been there for a while and relapse and relapse and relapse and keep coming back. And you're going to have people that are really new that finally got comfortable out of their shell, and you created a monster. It's wonderful, right? And, to see the wallflower come out and become very gregarious and very outgoing and all this, it's terrific. Got to be managed. But now they want your position. So now what you're going to do is you're going to try to do therapy on their cohort. Okay. And sometimes they'll get angry at you, especially if in the beginning you sat there and you says, oh, I'm not an addict. They're going to get angry at you because they're going to sit there and they're going to say, don't tell him that because you don't know what he's talking about. You've never used. See, that's why my thing when I'm asked that question is to sit there and say, well, I really don't answer that question. Because if I answer the question that I am an addict, you're going to want to know what it is and all that, and how long I've been in recovery. It's really not about me. It's about you, and it's not really your business, with all due respect. So I don't answer that question. And if I tell you that I'm not an addict, then what's your response going to be to me? It's going to be, well, what are you doing sitting there? Because you don't know what I'm going through. So I tell you what, I'm not going to tell you if I'm an addict or not. Stay with me for however long you need to be in treatment here. And at the end of treatment, come back and ask me because you'll know by then. I guarantee it, you'll know by then. So treatment goes on and it's time for the patient to leave. And the patient remembers that session, sister, and says, "So, doc, tell me, are you an addict or not?" I'm going to redirect it back. What do you think? "Oh, man, doc, I think you were a garbage head. You must have used everything." "Okay. Well, did you or didn't you?" "If you think I did, sure I did." "Doc, you're not telling me." "Sure I am. If that's what you believe, did it help you?" "Yeah, it helped me." "Okay, that's all that matters." Now, if the person's sister says, "Nah, doc, there's no way you're a drug addict." Okay, you're right. Maybe I was. Maybe I wasn't. What were you or weren't you? What do you think? Think you were. Okay. But doc, no. Did it help you? Did this group help you? Yeah. Well, then why does it matter? You're right. It doesn't matter. And that's the way it goes. All right. Believe me, I've done this so many times, and we usually leave with a chuckle and lots of compliments between each other. It's not about you, the therapist. It's about right when you reach stage two of Yalom's theory, and they try to dock you for position. Stop it. You are the clinician, not you control the group, right? And if they try to sit there and say, "This is my group, this is our group, it's not yours," you sit there and you say, "No, this is our group and I'm in charge of it. And if you don't like it, we can talk afterwards. But you need to cease and desist right now. And don't be afraid to put please don't be afraid to do that. It is your group. If your group goes out of control and you lose your seat in that group as the group leader, the group facilitator, psychotherapy is over, recovery is over because now control takes over. And what controlled the person in the beginning? Their substance, right? So, first stage of the group is talking through the therapist. Second, jockeying for position. Stage three of Yalom's theory is cohesiveness. Now, this comes after some time, usually about after six or eight groups, sometimes a little bit more, where the group gets comfortable with themselves and the group is self sufficient. Theoretically, they don't need you anymore because they get comfortable with one another and they start talking and processing almost immediately. Okay. I've been in groups where I sit down and I'll sit. How's everybody doing today? Oh, I'm doing fine. I'm doing fine, doc. Yeah, but I do have an issue. What's the issue? What's happening? Well, hold on, Mary. I was looking at you the other day and I was really concerned about you. Are you okay? Now that doesn't mean they're running the group because you're just sitting there observing and they're interacting. Mary will start to talk and somebody else will chime in and you can chime in and look around the group and say, "Well, Mary, do you mind this?" "No, no, okay." "Sydney, you're very quiet today. I'm noticing something on your face, the nonverbals. Read them and call them. I'm noticing. What am I seeing there?" So in Yalom theory, the idea is to be part of the group, to join with a group, but know how to join with that group, right? Because you got to understand those stages when they talk through you and to you, and then when they try to jockey for position, and then when they become cohesive and run their own group. One of the very interesting things, and you'll see the leaders as they come out. By the way, this is also an interesting dynamic in the group. When you're doing a group, you'll see the leader arise, and what happens with that is the leader will turn around in the group, and let's say group starts at 9 o'clock. 9 o'clock, everybody is there but you. You walk in about 9:05. You do this, but don't do this too often. Do this once or twice. You walk in 9:05. Nobody's sitting in your seat. And all of a sudden, when the group is cohesive, guess what'll happen? They won't even know that you're there. You walk in, you sit down, they're going to be processing, and then somebody's going to come up and sit there and say, "Oh, Doc, you came late. Sorry about that." Here's your leader. Okay. Or if you're sitting there and you're processing the group and somebody, it shows concern for somebody else, speaks up first, look for leadership qualities there. Use those skills, use them. Because if they're a leader in a group, then they can become a leader in your life. I'm sorry, in their life. In your life too, if you want, but in their life, okay? And through their example, you want to affirm this. And through their example, they can make leaders out of other people in that group that have no idea what leadership is like. But you have to remain neutral in this. And another thing about group process, every therapist is going to have their favorite patients. You know, throughout the years I have, but I never let them know who my favorite patient was. And and you gotta keep it close to your chest. Seriously, like I said, we're going to have them. Keep it close to your chest, okay? Because what you don't want is jealousy within the group, which can happen. Because if you got your favorite patient that's doing everything, and they are, and they're doing great and all this, and you start giving them things to do. You know, Mark, could you hand out my papers? Great. Pass them out to everybody. Mark, could you please put the coffee on for the group? Great, thank you. Mark, could you collect the papers back? Everybody's going to sit there and say, what's going on here? You know, Scuderi's over there doing, giving Mark everything that must be his favorite. Now all of a sudden everybody starts to go against Mark. Now what happens is Mark starts to have problems. Not a good thing. You want to treat everybody the same. Mark, could you pass out these papers for me? Sure, Doc. Thanks. Okay, great. Billy, could you do me a favor? Could you get the coffee started today? Okay, sure, Doc. Thanks. Right. Mary, could you do me a favor? Could you check and make sure that get different people to do different things? And then somewhere in the process, you sit there and you say, you mention it, you know, I asked you folks to do certain things, and I really appreciate you helping me out. How does it feel to have my confidence? Put yourself in that position. How does it feel to have my confidence in you that I know you're going to do something? Even if it's something simple like passing out papers, what does that feel like? Some of your patients is probably the first time in their life that somebody ever, you ready for the word? Trusted them. There's another group. A group of, okay. All right. In conclusion of this, there are several different types of groups that I hope you look into. You've got your psychoeducational group. That's a group where you just sit up in the front of the room. You can have 100 patients. It doesn't matter. And you don't need a co-therapist because you're basically learning from a script. You're taking a text, you're taking a book, you're taking some type of education that is in the uh, treatment, the clinic, and you're teaching the patients. Okay? This is why it's important for you to learn how to do PowerPoint presentations because you may be called upon to do a educational, and you may have to put a PowerPoint together to learn how to do it. Next one is a psychoprocess group. It's basically where everybody starts talking. Psychoed, you got psychoprocess, right? Um, and it goes on from there. Many different types of groups from there. Um, all right, so that's basically how to do group. I'm going to stop this right here for you guys, and the next time we talk, which will be a little bit later on in the week, I want to talk about individual therapy and how to do that. The second portion of the PowerPoint in the beginning that I gave you. I hope this helped. I'd like your feedback on it. Please let me know and take care.